Good morning. This is Kathy Kenny, and I'm pleased to be one of the moderators for the 2013 Primary Care Leadership Program Scholar Colloquium on Chronic Disease Management. On the next two slides, I've identified the scholars whose work I will be presenting today in this webinar. I've also included their placement site, school, and their topic. These are available for your review, but I also have individual slides of their work, and I will be discussing each of their projects. Today in the United States, chronic disease is the major cause of disability and is the main reason why people seek health care, and it also consumes 70% of health care spending. 49% of Americans have one or more chronic disease. Patients with a chronic disease find that their life is irreversibly changed. Neither the disease nor its consequences are static. They interact to create illness patterns requiring continuous and complex management. In contrast, management of acute disease treatment aims to return the patient to their normal healthy state. The U.S. healthcare system is good at treating short-term problems like fractures and acute infections. However, the key to effective chronic disease management requires understanding of the different trends in the illness patterns and the importance of patient engagement and focus on health literacy. Our population is aging. Chronic conditions such as diabetes, heart disease, lung disease, and Alzheimer's disease take a heavy toll on the health of our country. For example, obesity increases the risk of developing conditions such as diabetes and heart disease. The rate of obesity in adults has doubled in the last 20 years. It has almost tripled in children 2 to 11 years of age and has more than tripled in children aged 12 to 19. Without changes in our health care, 1 in 3 babies born today will develop diabetes in their lifetime. Average healthcare costs for someone who has one or more chronic conditions is 5 times greater than for someone without any chronic conditions. Chronic diseases account for every $3 of $4 spent on healthcare. The amounts are staggering. For heart disease and stroke, $432 billion per year. Diabetes, $174 billion per year. Lung disease, $154 billion a year, and Alzheimer's disease, $148 billion a year. And this is only one section of chronic disease that we deal with in the United States each year. 8 of the GE National Medical Foundation primary care scholars have addressed the issues of chronic disease management with innovative projects. I'm pleased for the privilege to present and summarize their work of this summer. On the next two slides, I've identified the scholars whose work I will be presenting today in this webinar. I've also included their placement site, school, and their topic. These are available for your review, but I also have individual slides of their work, and I will be discussing each of their projects.
Hello, this is Ryan Beckett. I am a second-year student in the MD program at Michigan State University College of Human Medicine. Over this past summer, I was placed at Wesley Community Health Center in Phoenix, Arizona. While I was there, I conducted a project looking at differences in diabetic self-management amongst insured patients and uninsured patients. In order to do that, I did a couple things. First, I did a chart review looking at patients and their hemoglobin A1C levels, their body mass index, and their cholesterol levels. The hypothesis was that the A1C levels, which measure blood sugar over the period of the past few months, would be lower amongst the insured population, as well as with the body mass index and the total cholesterol levels also would be lower, indicating that the insured population was doing a better job managing their diabetes versus the uninsured population. What I found was that there was a statistically significant difference in A1C levels. They were lower amongst the insured population, indicating that those individuals were doing a better job controlling their blood sugar. However, for the body mass index, it was actually reversed, where the uninsured population had a lower body mass index as compared to the insured counterparts, indicating that they were doing a better job looking after their weight. And then total cholesterol levels did not show any appreciable differences between the two groups. The other thing I tried to do was to come up with a survey that would look at patient attitudes toward their health care, and how that varies along with insurance status. It was my thought that there could be two possibilities. Either the uninsured patients felt like they had little margin for error, so they had to do a better job staying on top of their health, or maybe they just gave up on it. They felt like no one really cared about their health, so they would have a pessimistic attitude and not be as involved in their own treatment. Unfortunately, I wasn't able to distribute the survey to enough of a sample size to really come up with any appreciable differences, so that would be something I would recommend in the future, is maybe trying to distribute that survey more. And also there were some general sampling size issues. Most of the patients at Wesley are uninsured, so if we could get more insured patients into the population that are similar in demographics and economic level and some of those other variables, that might be interesting to look at, as well as maybe comparing A1C values within the patients over time. I tried to do that a little bit, but there weren't a lot of samples on that either. As far as generally, it was a great opportunity this summer to work with attendings and to hone my clinical skills and really get to interview patients and interact with them. And it was wonderful to see all the valuable things that Wesley does for a community that is so often underserved and overlooked. So I really had an enjoyable experience and took a lot away from it.
Hi everyone, my name is Mary Huang and I'm currently a second-year medical student at Midwestern University, Arizona College of Osteopathic Medicine. My independent project for the Primary Care Leadership Program was to investigate the dietary behaviors, perceptions, and barriers in patients at risk for type 2 diabetes mellitus at the Frank Bryant Health Center. My site was CommuniCare Health Centers in San Antonio, Texas. One of San Antonio's biggest public health concerns is the prevalence and incidence of type 2 diabetes. My first question was, why is diabetes such a problem in San Antonio? And then I asked, does diet play a role in the onset of type 2 diabetes? My curiosity about the San Antonians' dietary habits led me to ask the main question of my project. What are the patient's dietary behaviors and perceptions, and what are the barriers to healthy eating? In order to answer this question, I came up with a 30-item survey, which I gave individually to adult patients in the waiting rooms at the primary care clinics at the Frank Bryant Health Center. The survey first asked patients to describe a typical day's diet, what they ate for breakfast, lunch, and dinner. Then it asks to provide some demographic information and diabetes history information. The diabetes history information is important because it allowed me to stratify my patients into the at-risk for diabetes group or the non-at-risk for diabetes group, based on the responses to the following questions. 1, do you have a family member with diabetes? And 2, have you ever had gestational diabetes? If one of these questions was answered with a yes response, then the patient was put in the at-risk group. So the patient answered with a no response to both questions, they were put in the non-at-risk group. Next, I listed a series of statements, and the patient could choose to either agree or disagree with them. Some of the statements assessed whether the patient perceived the following to be barriers to healthy eating: availability, cost, social environment, or difficulty in food preparation. Other statements assessed how the patient perceived themselves in regard to their eating habits. I collected a total of 44 surveys, with 33 in the at-risk group and 11 in the non-at-risk group, based on the criteria previously mentioned. Key findings in my project were as follows. I found that the majority of patients were overweight or obese. Diabetes education is lacking in more than half of the at-risk group. For the at-risk group, cost and preparation were the two greatest barriers. For both groups, social environment was the greatest barrier. And finally, patients seem to lack health literacy on nutrition. based on their responses to their typical daily diet and their answers to the statements regarding their self-perception of eating healthy. Based on these findings, I recommend the following. First, an emphasis on weight loss in overweight and obese patients, especially since weight loss can significantly reduce one's risk for type 2 diabetes. Second, provide proper nutrition education, especially for patients at risk for type 2 diabetes. Third, involve friends and family members in changing dietary behaviors. This recommendation addresses the issue that the eating behaviors of friends and family are highly influential on the eating choices that the individual makes. Additionally, I think it's important to create a culture that supports healthy lifestyle choices. In order to do this, CommuniCare can partner with organizations such as the Texas Diabetes Institute to provide, for example, cooking classes that teach culturally relevant and inexpensive food preparation. In general, community health centers can partner with local diabetes prevention programs to create a more widespread attention to and practice of healthier lifestyle choices. And with these changes, hopefully we'll see a marked decrease in the incidence and prevalence of type 2 diabetes in San Antonio. Participating in PCLP has given me an invaluable opportunity to experience firsthand the leadership, clinical, and research aspects of providing healthcare to underserved communities. I'm extremely grateful to GE and National Medical Fellowships for providing me such an incredible opportunity. Thank you so much for your time.
Hello, my name is April Denise McNeil. I am a second-year medical student at Southern Illinois University School of Medicine in Springfield, Illinois. I had the pleasure of being placed at Central Mississippi Health Services in Jackson, Mississippi this summer. My project focuses on metabolic syndrome, a preventable and treatable cluster of conditions. My objective was to address the clinical aspect of reducing the prevalence of metabolic syndrome in the communities served by Central Mississippi Health Services in Jackson, Mississippi. I was able to identify patients that met 3 out of the 5 diagnostic criteria to be classified as metabolic syndrome to include in the study. These criteria included a waist circumference in men greater than 40 inches, in women greater than 35 inches, HDL levels less than 40 milligrams per deciliter in men and less than 50 milligrams per deciliter in women. Triglyceride levels greater than 150 milligrams per deciliter in both men and women. Blood pressure greater than 130 over 85 milligrams per mercury in both men and women. And fasting glucose greater than 100 milligrams per deciliter in both men and women. Gender, age, ethnicity, current diagnoses, and lab results associated with individual risk factors were obtained from the clinic's electronic medical records. In addition, waist circumference was taken from each patient identified with metabolic syndrome. Identified patients were surveyed and educated on the complications associated with the syndrome, as well as appropriate lifestyle modifications. Key findings included 39 out of 155 patients met diagnostic criteria for metabolic syndrome. It is to be noted that this patient population was only the number of patients that was seen by one provider in which I was assigned as a mentee. 29 out of the 39 patients were diagnosed with hyperlipidemia. 38 had hypertension. 34 had central obesity. 27 had diabetes. The answers to the study survey questions corroborate lifestyle risk factors such as overnutrition, atherogenic diets, and sedentary lifestyles that are the primary cause of the increased prevalence of metabolic syndrome. At the conclusion of this study, I recommended that the clinic implement a version of the metabolic syndrome tool outlined by the American College of Preventable Medicine to provide comprehensive care for patients diagnosed with metabolic syndrome. After discussing my project and research with my mentors and providers of the clinic, it was made apparent that it's not as easy as it sounds to actually implement such a plan because there are so many factors that contribute to providing quality health care to the patient population. One of the things that stuck out the most to me was social determinants of health that sometimes inhibit healthcare providers from actually providing the quality care that it would take to have reduce such syndromes and metabolic syndrome. So if given the opportunity, I would love to do a project focused on social determinants of health in the Jackson, Mississippi area. I would also like to include children in and educating them and their families on how to live healthy lifestyles to prevent such illnesses that are associated with metabolic syndrome. Again, thank you for this wonderful opportunity, GE, National Medical Fellowship Primary Care Leadership Program, for this wonderful opportunity. It was definitely a worthwhile experience and something that I will remember for a lifetime. Thank you.
Good evening, everyone. My name is Whitney Walborough, and I'm a second-year medical student from Morehouse School of Medicine. This summer, I was placed in West Memphis, Arkansas, at East Arkansas Family Health Center. And while I was there, I basically spent the first couple of weeks of my program observing the community health center. So I took the time to watch the physicians, to watch how they interacted with their patients, as well as just talk to their patients and see what kind of things they were struggling with throughout their day-to-day life. So, in doing this, I found that a lot of patients at East Arkansas Family Health Center struggled with diabetes. So I decided to center my project around the identification of obstacles that prevented patients from effectively managing their diabetes. In order to do this, I conducted key informant interviews of the providers, nurses, and key individuals at East Arkansas Family Health Center, as well as patients of East Arkansas Family Health Center, since they were the ones who were struggling with the diabetes. I asked each group member a specific set of questions in order to determine how well controlled their diabetes were, or if it was a provider, how well controlled they thought their patient's diabetes was. In addition to this, I asked patients to rate how well they thought they controlled their diabetes, as well as just what type of foods they ate on a day-to-day basis, what type of exercise, if they did exercise, and how their just overall lifestyle of living, whether or not they prepare their own food, or if they had people prepare their foods, whether or not they did their own grocery shopping, different things like that. The last tool I used in order to assess how well controlled the diabetes was at East Arkansas Family Health Center was using their EMR record, electronic record system, in order to get the actual number of their patients with their hemoglobin A1Cs, and I used this to basically assess how well controlled the patient's diabetes was. After conducting patient and provider interviews, I identified 4 major areas that acted as barriers to the control of patient diabetes. The first barrier was centered around a lack of money and proper insurance. So basically with this, many patients stated that because they didn't have enough money, it tended to hinder them from buying foods that were healthier for them, as well as just purchasing medication needed in order to effectively control their diabetes. The next barrier was a limited access to quality food options. So basically many patients stated that within East Arkansas, there were only 2 major grocery stores. And because they were on completely opposite sides of the town, it tended to be very hard to get to them. So they tended to eat fast food, which was highly populated around the area that they lived in. So that was one of the major barriers as well, not having quality access to healthy food options. The next barrier was an inadequate understanding of how to properly prepare diabetic-friendly meals. And this more so just centered around on how many of the patients were raised. They were raised on Southern cooking, so fried chicken and cornbread and different things like that, collard greens. So a lot of foods like that, which are high in sodium, high in sugar, didn't tend to be the best options for somebody who was struggling with diabetes. But because they were never taught the importance of eating fish as opposed to fried chicken or eating fresh fruit as opposed to canned fruit, it tended to hinder their control of their diabetes. The last barrier that I identified was the simple inflation of the level of control. Many patients, when asked whether or not they thought their diabetes was controlled or how well controlled they thought it was, many people rated themselves that they thought that they were very high controlled or very well controlled, that they knew how to manage their diabetes properly. But when I looked at their hemoglobin A1C levels, many of them had numbers that were through the roof, which showed that they weren't as controlled as what they thought they were. So because of this, I recommend that East Arkansas Family Health Center hires an on-site registered dietitian. And the importance of an on-site registered dietitian would be that this person would solely be in charge of helping patients who are struggling with chronic illnesses. This person would be in charge of monitoring the effectiveness of patients who are struggling with certain chronic diseases. They'd be in charge of making sure they're eating what they're supposed to eat, making sure they're exercising, as well as providing them with different recipes that are healthier food options for people struggling with chronic illnesses. In addition to this, East Arkansas should look into continuing medical education programs, which are basically centered around educating patients as well as their families / support systems on different chronic diseases and illnesses. And I think in doing this, it can help patients. I think in involving the family, it helps patients better overcome / succeed in the control of whatever illnesses they are struggling with. And lastly, I know this may not be as feasible, but I do also recommend that East Arkansas invest in doing home visits to certain patients, because while being in East Arkansas, I was able to go to a couple of home visits, and I noticed that patients got a lot more embarrassed, I guess I should say, if they saw you check in their cabinets and see what was in their cabinets or refrigerators. So, investing a little time in going to see the patients and going to see what they're eating will kind of encourage them and help foster them to better control their diabetes. So in closing, I just want to say that I really did enjoy the primary care leadership program. I really cannot stress that enough. I think that it gave me an opportunity in order to look into what patient care is, and not just on the outside simply shadowing, but actually going into a community health center, accessing what I saw as an area of need, and then giving suggestions on how to fix those needs.
Hello, my name is Lanaya Odom, and I'm a second-year medical student at Meharry Medical College in Nashville, Tennessee. This summer, I spent time at the Healthcare Center for the Homeless in Orlando, Florida, and my independent project analyzed the effect that living arrangements have on control of diabetes mellitus. Diabetes is prevalent across the country, but it's also the second most prevalent diagnosed chronic illness at the center. And in light of this, we decided that it would be a great area to research, and more importantly, for the patients that are served by this center, those that are both housed and homeless, we wanted to see if there was a difference in their hemoglobin A1C levels. We also took a look at gender, race, and ethnicity within those categories as well, to see if there was any significant difference in the hemoglobin A1C levels. So basically, we picked a random sample of patients from June 2012 to May 2013 using the electronic health records, and we recorded their hemoglobin A1C level their housing status, gender, race, and ethnicity. And of course, these are all demographics from diabetic patients. And then SPSS was used to do frequency tables, sample t-tests, and one-way and two-way ANOVA to test the mean difference, if there was one, between the two groups, and then also to see if that difference was significant. So what we found was throughout all the groups, there was actually no statistically significant mean difference in hemoglobin A1C levels between either homeless and house patients, as well as across gender, race, and ethnicity. Interestingly enough, the two groups with the highest mean hemoglobin A1C were homeless Hispanic patients and homeless Haitian patients, both of which are extremely prevalent at the clinic. However, also when homeless and housed were used as the categorical controls, there was no mean difference found between any of those demographics that I mentioned before. Another thing that was extremely notable that's worth mentioning is that the way in which the hemoglobin A1C levels are recorded for both of these populations deserves mention. House patients use the LabQuest, and LabQuest is directly interfaced with the center's electronic health records. So once patients go for blood tests, all their levels are directly recorded in the system. However, for homeless patients, their labs are processed through Florida Hospital, and Florida Hospital isn't interfaced with electronic health records, and so those results are subject to human error as well as omission. And so the data set that I had perhaps could have contained HbA1c levels that were entered in error or were simply omitted in terms of recency for the patients. Another key finding was that patients who use our mobile unit, which is typically reserved for patients who live in a remote area, they do not have access to our diabetes educators, nor do they have access to diabetic education materials in a language other than English. So amongst my suggestions, providing that information in both Spanish and Creole, that was of extremely high importance, as well as possibly using volunteers and training them to serve on the mobile unit and provide diabetes education, just like the volunteer clinical pharmacists do at the main clinic in downtown Orlando. What was surprising and notable and very, very positive for the clinic was the fact that all of the mean hemoglobin A1C levels were at 9 or below, which according to national standards for clinics, that's excellent. However, the American Diabetes Association, of course, recommends that hemoglobin A1C levels be 7% or below to minimize vascular complications and limb amputations. So overall, the clinic is doing decently well. However, just like anything else, there's always room for improvement. But I gained a deeper understanding for the intricacies of diabetes, how it affects underserved populations in indigent areas, and I certainly did not expect homeless and house patients to pretty much have the same HbA1c on average. I really expected house patients to have a better control because they're privy to resources and a roof and perhaps family or friends that can allow them to refrigerate their medication or remind them to take it or bring them somewhere to refill it. And however, homeless patients, are at a disadvantage. But from the sample that we had and the tests that we ran, the levels were pretty much the same. And I must say that both my faculty and clinic advisor were just as taken aback as I was, but also happy to know that on average, the levels were within health and human services levels that they report, and certainly aiming to bring those average levels down to 7% and below to benefit patients in the long run. So it was an excellent project. I'm glad that I used such a prevalent chronic illness and something that affects so many people worldwide even, but much more so for this clinic in particular. Many of my colleagues mentioned that they look forward to using this information to improve their patient diet regimes, exercise encouragement, and management of their medication to ensure that they're getting the best treatment possible. So PCLP was a great experience. The independent project went well, and thank you very much for the opportunity.
Hello, my name is Emily Peters. I am a second-year physician assistant student at Midwestern University in Glendale, Arizona. I was placed with Altamed Health Service Corporation in Los Angeles, California. My independent project was an analysis of Altamed's HIV screening and diagnostic rates following the implementation of universal testing policy. The CDC recommended in 2006 that everybody should be tested for HIV in a clinical setting if they are the ages 13 to 64. Altamed implemented this policy mid-year 2010. I worked with the medical informatics team at Altamed to collect my data. My baseline period was July 1st, 2009 to June 30th, 2010. Unfortunately, Altamed implemented the use of EMR mid-year 2009, so I can't go further back than that. My intervention period was July 1st, 2010 to June 30th, 2013. We looked at the total number of unique patients screened and the total number of positive HIV results during both of those periods. We also looked at demographic information regarding the patients who tested positive. This included race, age, and sexual orientation. Key findings of my report showed that during the baseline period, only 7.18% of Altamed's patient population was tested for HIV. After implementation of universal testing, the screening rate rose, and by 2013, the screening rate was 41.9% of the patient population. The diagnostic also rose after implementation of the policy. There were 14 cases of positive HIV in our baseline period, and there were 191 positive HIV cases in 2013. My report is nothing earth-shattering. We are offering more tests, so it makes sense that we're going to have a higher screening rate, and we are going to have a higher diagnostic rate. However, my report was really for Altamed to use as an internal report to help them set goals for the future. I recommend that Altamed uses my report in 3 different ways. It should be used to set goals regarding their HIV screening rate for the future. Now they're at 41.9%. Maybe they can use this to set a goal of 50% or 60% by next year. I also recommend this report used as a catalyst to start exploring how NextGen can improve on their pop-up reminders regarding HIV testing. Throughout my process, it came to be known that it's really easy to bypass some of these pop-up reminders regarding HIV testing. So maybe Altamed should look into this more, and hopefully this report brings that process around. Lastly, I think my report should be used to educate all Altamed employees regarding the corporation's progress in HIV testing. It's a national goal to reduce the number of individuals who are unaware of their serostatus from 20% to below 10% by 2015. I think by making everybody at the corporation aware of their progress, we can all work toward achieving that goal. I really enjoyed working with Ultimed. I think it's a great corporation. It taught me a lot about community health centers and the way to offer medicine and clinical practice. In such a setting, I was very unfamiliar with community health centers prior, so I learned a lot. It was a great experience to be a GE NMF PCLP scholar, and I really liked it. So thank you for the opportunity, and thank you for listening.
Hello everyone, my name is Lauren Sheard and I'm a second year medical student at the University of Illinois at Chicago College of Medicine in Chicago, Illinois. Through the GE NMF PCLP program, I was placed at the Matthew Walker Comprehensive Health Center, which has 3 sites across the state of Tennessee, but the main site is in Nashville, Tennessee. So this summer, I executed a needs assessment project at Matthew Walker entitled Quality Improvement Initiative for the Classification of Pediatric Asthma Patients in a Community Health Center. The objectives of my project were threefold. First, I wanted to compare pediatric asthma prevalence in a community health center to statewide prevalence of pediatric asthma. Next, I wanted to determine the proportion of individuals under the age of 19 with asthma within a community health center, specifically at Matthew Walker, whose asthma severity has been or be classified according to the National Heart, Lung, and Blood Institute's asthma severity classifications for children. And then lastly, I wanted to determine the incidence rate of emergency department visits per patient in the 12 months prior to the start of this asthma quality improvement initiative for children with asthma being treated at Matthew Walker Comprehensive Health Center. So the way that I went about executing these objectives is listed right there on the slide, but in some I made use of Matthew Walker's electronic health records. So first, I just identified patients with asthma that were 19 years of age or younger that were treated in 2012. I then extracted relevant patient data from the identified sample set, and then finally I just analyzed the data based on the objectives that I was studying. Using these methods, I discovered the following. So first, I discovered an apparent underdiagnosis of pediatric asthma in this community health center, and this is linked to patient data suggesting that only 3.5% of patients under 19 treated at Matthew Walker in 2012 had a diagnosis of asthma, and this was of course in comparison to the statewide prevalence, which in Tennessee the prevalence of asthma is about 9.5%. So the inference of underdiagnosis was based on several research studies citing that minorities, specifically non-Hispanic Black children and Hispanic children, are more likely to be diagnosed with and then still have asthma in comparison to non-Hispanic white children. Similar studies found that children from low-income families have an increased burden of asthma as well. So based on the fact that minorities and children from low SES families make up a significant proportion of the patient load being serviced at Matthew Walker, I was expecting patient load to be a lot higher in comparison to the statewide prevalence. Next, I found that only 17% of the patients identified as having asthma were properly classified based on asthma severity, and this was according to the most recent classification standards suggested by the NHLBI. And then lastly, what I wanted to do with the last objective was basically, I wanted to look at ED visits in the hope of proving that if Matthew Walker had a higher percentage of properly classified patients, that the number of ED visits would be lower. That is to say that if you're properly classifying children based on their asthma severity, then they would have fewer asthma-related complications and therefore fewer ED visits. But since I only found 17% of the patient record been included adequate data, I basically just concluded that the data regarding ED visits and disease complications was inclusive in this study. So, to conclude, my ultimate recommendation for the team at Matthew Walker was to simply standardize the way patient information is collected and stored. I based this recommendation off of the fact that after collecting my data, I found that proper asthma severity classification measures were actually being taken by several of the providers at Matthew Walker. However, this information was not being duplicated in the electronic health records and therefore was not accessible to all providers. To kind of remedy this situation, I drafted a standard form directly based on the NHLBI severity classification measures, and I presented this to the team in English and in Spanish and suggested that perhaps uploading this or a similar form directly into the electronic health records would help to ensure that all providers were seeing the same information for each patient. And it would also ensure that this information was in line with what the NHLBI recommend for classification of asthma severity for children. So, just to reflect on this project, just another underlying issue that arose was an obvious lack of communication between providers. So, for example, while I was giving my presentation, it was made known that a similar form, similar to the one that I drafted, was already uploaded onto the electronic health records, but no one was making use of the form. And the majority of the providers that attended my presentation had no idea that the form even existed. So there was a clear just lack of communication there. Also, this communication issue was observed when it came to sharing patient information. So there were several key provider to patient interactions, for instance, between the respiratory therapist and a patient with asthma. Several of these interactions, the patient's primary care provider didn't even know anything about these interactions. So again, just making full electronic health records as a resource to keep every provider that may encounter a particular patient in the loop about what's already been accomplished is just one sure way to combat like overlapping procedures or treatments and even simple conversations. So that's it. Thank you so much to the GE NMF PCLP program for this wonderful service learning opportunity. Thank you.
I would like to recognize the very good projects and the amazing amount of effort that was put into these projects by the scholars. They all identified issues in clinical practice that we face daily. When I put together a synthesis of the projects, rather than recap what the results were from the studies, because I did describe them with information taken from individual papers as well as the slides that were presented, there are a couple points that I think are important to make. Billions of dollars are spent each year in the U.S. for care of patients with chronic diseases and their complications. Chronic diseases are more prevalent in patients who are uninsured or underinsured. The importance of environment and socioeconomic class cannot be overlooked because this impacts the incidence and treatment of chronic disease. And the treatment of chronic disease is complex with many barriers that include, as we saw in many of the reports, money, lack of education about disease processes and treatment, lack of education on how to implement and sustain lifestyle changes, lack of social and family support, and environmental issues also play a very large part that include difficulty or inability to find and purchase fresh produce and healthy foods, and the high availability of fast food restaurants. The last 2 points I'd like to discuss are listed here. As we saw in many of the presentations, diabetes control is key in preventing associated cardiovascular and renal complications. Despite improved treatment options, patient outcomes are lagging. We've recognized that lifestyle changes are key to improving outcomes. However, we also see that it's difficult for patients to initiate, implement, and sustain these lifestyle changes. Nutrition counseling resources are lacking in many community health centers, but also are lacking in primary care practices and also acute care facilities where patients who both our insured and uninsured are evaluated. And I won't belabor the point, but I think it's important to bring up that electronic health records often make it difficult for providers and researchers to obtain accurate data. Many of the systems are difficult for providers to enter information and review information to make meaningful conclusions regarding care outcomes. And the other issue is that electronic health records, as we know today, often do not communicate with other clinics or providers, thus providing a barrier to efficient and cost-effective care that could be implemented if information could be shared. In closing, once again, I want to recognize the excellent work and the effort that the scholars have put into their work this summer. I'd like to pose a few discussion questions to think about, and these are not necessarily directly related to the projects that were done, but I think as current and future healthcare providers, they're important to think about. First of all, what is the potential for the Accountable Care Act to impact chronic disease management? I think this is especially important as we're moving through some turbulent times now within our Congress as to decisions that might be made on where this act is it going to move forward, is it not, and what are some of the recommendations, how might they change? Secondly, as healthcare providers, how do we identify a target population to focus on health promotion activities to prevent delay of the onset of diabetes and other chronic diseases? At what age should this start? And this is focusing really on true health promotion efforts that we can stop the diseases before they even begin or delay the progression and onset of chronic disease. And another important topic to think about is how does interprofessional education and practice impact health outcomes of the underserved and vulnerable populations? So with that, I will thank you very much for your attention, and I hope you've enjoyed the summary of our scholars' work this summer. And once again, I appreciate the privilege and opportunity to be part of the Primary Care Leadership Program. Thanks so much.